Thank you for attending Acrest Health Talk today. So the topic will be about cancer treatment, immunotherapy, and clinical trial. Before Dr. Stanton's presentation, I would like to invite Twin Tran to share her great works at the Providence Cancer Institute. She has been a great partner for our ACREST program from the beginning and a strong advocate for the Asian community. She received a Master of Public Health Administration degree at Portland State University in Oregon. She currently works as a cancer control program outreach specialist. Her areas of focus include community health promotion, and cancer screening and prevention education, advocacy and health disparities in underserved populations. She has been working with different groups to raise cancer health awareness through community cancer health screenings and educational prevents or events. Please welcome Twin Tran.
Good morning, everybody, and thank you for the introduction, and also thank you for inviting us, Dr. Stanton and myself, and also to represent for Providence Cancer Institute to join the presentation today. So you will have a very comprehensive and informative presentation with Dr. Stanton, but before that, I would like to take an opportunity to just give you a brief information about our patient support and patient resources available at the Cancer Center. And again, my name is Twin Tran, and I am a cancer control program outreach specialist at Providence Cancer Institute. And my work basically focus around cancer screening and cancer prevention. And also I work with different community partners such as the Asian Health and Service Center, just to hopefully to raise the awareness on cancer prevention and cancer screening, just to bring the information out to the community, and hopefully everyone will be aware of the how to prevent cancer, how to reduce your risk of cancer, and people can learn what cancer screenings available. But today I will just talk about the patient support. You can help me to move to the next slide, please. Next, yeah. And next, you can, next slide. Yeah. So the first one I would like to mention, which is the patient support. And with patient support at Providence Cancer Institute, there are many levels of care and support for patients. So in addition to the care team, such as the doctors and nurses, a patient also has additional support from our oncology nurse navigators, oncology social workers, and also the resource specialists. So with nurse navigators, they are available throughout a patient's treatment, just to answer any questions patients may have, and also help navigate appointments and connect patients to helpful resources. And with oncology social workers, they help with both emotional and practical concerns relate to patients' diagnosis, such as relieving anxiety and depressions, especially for patients when they first diagnosed with cancer. And also finding a support group that are available for patients and helping patients to get to their appointments. So they work like one by one with patients. And with the resource specialists, they are a part of my team, of our team, which is the cancer outreach team. So with the resource specialists, they help patients to, it's just similar to the lay navigators. So they help patients to find information about cancer. They cannot provide any medical advices, but they help to do research or to work with patient in terms of information, or they can provide patients with some resources like the wellness classes we have, such as the exercise or nutrition information. And also they help connect patients with support groups and other resources, or connect with nurse navigators, or connect with our social workers. So those are the three groups. They help to support patients throughout their cancer journey. Next slide, please. So I also would like to just talk a little bit about our resources. And the first one is supporting our patients. And could you please also click on the supporting our patients button? Hopefully it will direct you to our web page. It's nothing.
Can anybody see the screen? Or
I still see the slide.
how about right now?
Okay, good. Yeah. Yeah, so this is the web page. And this is the supporting our patients. And if you could help to, scroll it down. And there are different resources here. So we have financial support, support groups, peer support, and trusted resources, or transportation. And so our resource specialists or our social workers and nurse navigators, they will help to guide patients to this page in order to get more information, just to provide some useful general information and resources for cancer patients. And transportation is one of the major issues that we always encounter with patients. So it will help them to guide them to the resources available in the community. And thank you for pointing to the Living Well Guide that you see on the right side. And with the Living Well Guide, it's just that we developed this as a reference guide. So it's just one-stop resources for our patients with all the different contact numbers, support services, and also self-care information. And we have this in a few different languages, including the Asian ones like Chinese, Korean, and Vietnamese. And we have the printing copies available. And also at the Asian Health Service Center, the library, we also provide some of these resources. So another thing I would like to point out, what is the patient education videos. You see the little icon with the play button on the web page. And with that video, we just provide the patient with basic information regarding any common side effects beyond cancer treatment. And for the video, we have the patient, they share their stories, they share their personal experiences, and also with some practical advices from our medical expert. And another one, which is the screening and prevention page. The screening and prevention page is the information that we, oh, by the way, I'm sorry to mention about the patient education videos. They are in English, but we have the subtitle in different languages for each video. And for the screening and prevention page, so this page, we provide different information about cancer screening. And again, we have the flyer with general cancer screenings, like screening guidelines, and how to reduce your risk factors and how to reduce your risk in different languages also. And with the screening, like this is a part of my job that normally in the past, every year, we provide some free cancer screening to the community, such as we did the oral head and neck cancer screening and skin cancer screening and free screening for community. But again, due to COVID-19, currently we are unable to do our annual screening events, and we are uncertain what will happen in 2021. But we're looking for new ways to work with our community partners like the Asian Health Service Center, possibly having a virtual or online presentation like we are doing right now. And then another important component that really, I'm sorry, that's really helpful for our patients, which is the support groups. Yeah, so we offer several support groups such as the breast cancer, advanced cancer, and family support. With these groups, we provide education and support for cancer patients and their family. And the support groups are led by our professional staff, and they are offer free service to any person with cancer in our community. But again, due to COVID-19, now these groups are only available online. We used to have in-person and on-site support groups. You can help me to go back to the slides. The third one we talk about is the peer support. And with peer support, they are not medical experts, and they are just the trained volunteers who have had cancer. They are available to provide one-on-one emotional support and some general information to other cancer patients and also their families. I think it's slide number 8, right?
Sorry, my mouse is having some issues.
No problem. So with the peer support, patients, they have an opportunity to talk about their fears and their concerns with the trained volunteers. So that's why we call peer support. But definitely they cannot give any medical advices. So these are the resources we have available for patients. And again, they can work one-on-one with our oncology nurse navigators, our social workers, and also the resource specialists to help patients with these resources. The next slide is, I just want to show you the, because it's the learning centers, technically it's the library, the landing library, yeah. And we have 2 different locations. One is Providence, Portland. It's right on the first floor of Providence Cancer Institute. And the other one is at Providence St. Vincent, is in the breast center. But currently they closed due to COVID-19. Again, everything just they changed because of COVID-19. So with the learning centers, you see that they are the landing libraries. So we have information about different types of cancer and about support services that can help patients before, during, and also after treatment. They can lend books, or they can get booklets, brochures, and other cancer information available just for everyone in the community. And the last one is the transitions, and technically transition is just a shop for breast cancer patients. They have a post-breast surgery bras, they have hats and scarves, and the accessories for breast cancer patients. And we have at 2 different locations as well, at Providence, Portland, and Providence, St. Vincent. And it's just right next to the learning centers. Yeah, so I think those are my presentation today, and I just hope that I can just give you some information about the resources we have available at the center. And that is a part of our team, the Cancer Outreach team and the Cancer Support Services team, try to provide the support and the available resources to help patients throughout their cancer treatment journey. Again, thank you. And please let me know if you have any questions or if you need any information. I'm happy to provide that.
Okay, right now let's take about like 10 minutes for Q&A time.
Mhm.
So Twin, I do have a question. So for the brochure, if they request it, is Providence going to be able to send it to us, or just have to be like we have to read it from the computer, or do they send it to
Ye-
us, or?
Yeah, so currently we try to do everything online, but if you request for example with some depends on the quantity, and if you would like, we can also try to mail some to you. But all the information, yes, they are available online. But if you would like, let's just say, for example, with the brochures or the Living Well Guide booklets that we provided to the Asian Health Service Center before, if you would like to request for more with those kind of like booklets, it's hard to see, to read through the PDF, or if someone prefer to have a booklet for themselves, yes, please just send me a request and I will try to mail them to you.
Okay, thank you.
And people without private, who are not Providence patients can access these resources?
Yes, so for example, with the learning centers, if they, it opens for everyone in the community and for family, for patients and families. So if they are not Providence patient, they still welcome to come here, come to our library and to get the information, the resources. But for some other resources, for example, with our like working with our oncology nurse navigators or our oncology social workers as resource specialists, normally that we work with Providence patients like one-on-one. But if you just need information, or if you need to have a, for example, a second opinion, you're welcome to come to the learning center. But I'm sorry, right now we close, but you're welcome to reach out to us, or you can contact our resource specialists, and they will help you to direct you to the appropriate resource.
Can you tell us a little bit about your alternative cancer treatment like massage or acupuncture that it's also provided at the center?
You're talking about the integrative medicine, right?
Yes.
Well, can you help me to go back to slide number 4? And then you click on the supporting, no, next slide. And the first, the supporting our patients. Yeah, and then you see with the first icon, we have the integrative medicine. So thank you for asking about this one, but the thing is, because I'm not familiar with all the resources, the services they have here, but yeah, we do offer the acupuncture, and we have naturopath doctor there to, so if you go, you go to this web page and you will see the more information. And basically this is, they work side by side with with cancer treatment. So they help patients just to help them to feel better during their cancer treatment. And it depends on how the, how it, technically it depends on your cancer type to see whether it is effective and is helpful with the support from the integrative medicine. And with the massage therapy, we have the massage therapist there, we have acupuncture, and if you can visit this webpage, you will learn more information. And also before COVID-19, we also offer some exercise classes free for technically for patients and family. Such as you see on the right side, we offer the Qigong class, and it runs by our naturopath doctor. But now we have to cancel this class and we have to postpone until further notice because of we cannot get together as a group. And hopefully if we can come up with some different formats, such as they doing this virtually, we will have the updates on this web page. But for now, with this web page, we also have some, if you can scroll down a little bit, we have the resources. We have the Living Well Guide here again, and also we have some documents, wellness in the time of COVID-19, to talk about diet and nutrition, exercise, stress reduction is on the right side. You see with the picture with the lady, yeah. So these are the resources available for community, and we talk about with these subjects during the COVID-19, how to be healthy and how to keep your healthy lifestyle during this pandemic. Right, I'm sorry, currently they just available in English, but later on we will add more different languages for the materials. And at this point with the, so this group that we're working with directly with just Providence patients. So that's why if you can go to the webpage, and then I'm sorry that I don't have a specific information about this group, but you can learn about the services here and also our doctors here.
So this is Sasha Stanton, and I have to say, we, at least in the breast group, I'm a breast oncologist, and we work very closely with our integrative medicine doctors. They come to our tumor boards, and I have a lot of patients that are getting care here. It's a fantastic program because at least in breast cancer, we actually have clinical trials that show benefit of acupuncture and helping with some of the side effects that we get with the therapies we give. And I work very closely with these NDs, they're naturopathic doctors, and they're really fantastic and in working with us. So it's a really nice part of our whole medical care in
Great, yeah.
So I can speak to breast cancer. I haven't done this with others, but
Yeah. Thank you, Dr. Stanton. Yeah, because this is a very good information. And thank you for sharing, because I'm not working like closely directly with them. Yeah, but again, you can refer to this webpage and to learn more about the services we have available at this clinic. Is there any other questions? Yeah, so if we don't have any other questions, I really hope and I really try to encourage everyone to do the pre-test that we sent out before Dr. Stanton starts with her presentation, and your time is really appreciated. But it's just a few questions, but hopefully it's really important with your responses. So hopefully you can do the pre-test, and also after the presentation, you can help to do the post-test for the evaluation. Thank you.
Thank you, Tuen. We're really grateful to have you, and thank you for the very informative overview about the resources. And it will be really great resources for us. Thank you. Thank you for your time and your sharing.
Thank you so much for having us.
Welcome back, everyone. I will now introduce Dr. Sasha Elizabeth Stanton, who will be presenting about cancer treatment, immunotherapy, and clinical trials. So Dr. Stanton has an MD PhD from the Albert Einstein College of Medicine in New York. She completed her residency in internal medicine at New York Hospital, Weill Cornell Medical Center, and hepatology oncology fellowship at the University of Washington Fred Hutchinson Cancer Research Center. She also completed an immunology postdoctoral fellowship at the University of Washington Cancer Vaccine Institute and was promoted to assistant professor in 2017. Dr. Stanton moved to Portland, Oregon in January 2020 and is an assistant member in the Department of Medical Oncology in the Earl A. Childs Research Institute. Her research focuses on antigen discovery and vaccine design for breast and head and neck squamous cell cancer prevention vaccines. She's also interested in immune modification of the tumor immune environment of breast cancer. Her clinical work is with the Breast Oncology Group at the Providence Portland Cancer Center. Please help me welcome Dr. Stanton.
Hi, good morning. And you're controlling the slides? Perfect. Next slide then. Today I'm going to be doing a really broad overlook of immunotherapy options in cancer, and also trying to give you some information about these options and what we have at Providence Portland. But at the end, if you have any questions that I can answer, I'm going to give you my email, and please feel free to reach out to me. As in the introduction said, I am a New Yorker. I tend to talk fast. So also please let me know if there are any questions or clarifications that I can help with. Let me go to the next slide. So in getting ready for this talk, and I really looked over what was important to consider in Asian American populations about cancer. And the first thing I came across was a huge problem with that, which is that when we in the United States look at Asian American populations, we tend to group everybody together, and there are vast differences, as I know you all know. So there are many populations, and often our national data sets don't take this into account. What I can say is that cancer is the leading cause of death in Asian Americans, and this is actually common also in Caucasians, with lung, liver, and colon cancer being the highest in Asian American men, and breast, lung, and colon in Asian American women. And interestingly, and we are still doing research to figure out why, the cancer risks particularly seem to increase on immigration to the United States. So for example, in an epidemiologic study there was a 6-fold increase in breast cancer diagnosis in women who had immigrated to America as compared to women who had remained in Asia. And this is a complex, there are many complex reasons for this, but it's why really getting screening is important to watch for. Larger risk of liver cancers actually tends to be found in people who have been born outside of the US and in Asian countries. A lot of this thought to be the prevalence of hepatitis B, but that is very much changing as well with the hepatitis V vaccine. And so those data are definitely maturing as our therapies have improved. So just this is an important consideration for all of your group to really consider. Next slide. And so just in my research, I really do breast cancer. I do screening and prevention studies. So I always have to put a screening slide in, even though right now I'm going to be talking about therapies. So for colon cancer, and these are not Asian American specific, these are our recommendations based on a variety of different task forces. And I realize these can get confusing sometimes because different groups have different recommendations, but these are really sort of what we in medicine go by, which is colonoscopy starting at 50 years old for screening for colon cancer. And then subsequent screening will depend on what's found at the colonoscopy. If polyps are found, it may need to be more frequent. If they're not, it's usually every 10 years. And this will change if you have a family history of colon cancer or people who have colon cancer that have been diagnosed earlier than 50 years old. For breast cancer, typically what we recommend is that you talk to your doctor at about 40 about your risks. Do you have a family history of breast cancer? Do you have you had biopsies previously or lumpy breasts? That may trigger screening earlier than later, but at least by the age of 50, we recommend a mammogram every 1 to 2 years, along with clinical breast exams. For lung cancer, really this is if you had a heavy smoking history in the past, or if you were a current smoker. There is data for a yearly low dose CT CAT scan between about 50 and 75 years old, again, looking for very early lung cancers. Cervical cancer, women between 21 and 65 with getting pap smears about every 1 to 3 years. And prostate cancer, discuss this with your doctor. Usually it's a yearly exam starting at about 50 years old. Again, if there's a family history, sometimes they'll do a blood test called a PSA that they'll include along with that, that prostatic screen. Next slide, please. So then I'm going to be talking a lot today about things that are clinical trials, studies that we haven't actually had gotten complete data for, and we're still testing in patients. And clinical trials really are critical for us to move the field forward and to really find the best therapies. So there are many phases to a clinical trial, and these can start in the preclinical phase. So these are where we are discovering new findings. And these can take from 10 years to 5 years to just even before we ever go into a person. We tend to do our first studies in animals. I have a laboratory here at Providence, Portland, and I have mice that I tend to do my experiments in and test my vaccines in. And once we have all of the data from those preclinical trials, we bring our whole data package to the FDA, the Federal Drug Administration, and they review this. And it is something that's called an IND, or Investigational New Drug Application. And it is reviewed by experts at the FDA for what we've done, all of the preclinical work we've done, as well as the protocol or the study that we plan to move forward with, and they review it for, is this safe? Are we evaluating people enough for any possible toxicities? Are we doing something that is that we have enough good data that it's worth putting patients at risk to receive these trials? These trials for very early drugs are phase 1 trials. These trials tend to be small because, again, you want to, if there is something that might be a risk to patients, you want to give as few patients as possible this risk to make sure it's safe. These are studies that are really looking for safety. They're looking for what kind of side effects. They may be studies that have different dosing to find the best dose and the safest dose of a medication or a therapy. And so these are very small studies. They tend to not have a placebo or a control arm. They really are looking for safety. After these studies are done and the therapy is shown to be safe, you move into into studies that are looking more for efficacy. And these are phase 2 and then phase 3 trials. Phase 2 trials are a little bit larger, 100 to 1,000 patients. These may be randomized, where half the patients will get either a placebo, or in cancer, we tend to give people the standard of care, and half of the patients will get the standard of care plus a new medication to figure out if that standard of care, if that medication is better than the standard of care. And then if those are successful, patients will move to phase 3 trials. These are very large trials, 1,000 to 3,000 participants in oncology. These are where you'll see things that are called randomized and blinded. So in that case, neither the doctor nor the patient know whether they're getting the standard of care or the extra medications and things that are being, or therapies that are being tested. And this is a way to make sure that our results are not biased, that when we actually look at what's coming out of these studies, we can say, okay, we didn't know what we were giving patients, yet we saw this benefit, or we didn't see this benefit. In our current news, you're hearing about the phase 3 vaccine trials for the COVID vaccines, and they went through this exact same process. It was a little sped up because of the international crisis of COVID. But first, these companies had a phase 1 trial where they tested it on a small number of patients, and they made sure that it was safe and that they knew what the side effects were and what doses were the best immunology. They developed the best immune response and yet didn't give a lot of side effects. And they are now in these phase 3 trials, which are randomized and blinded. So you may be getting a injection of saline, or you may be getting the COVID vaccines. And so this is the exact same process we do in cancer trials, and we're kind of seeing it brought to form in our current COVID crisis. After the phase 3 trials, if a benefit has been seen, the drug is submitted to the FDA for approval, and the FDA really goes through it with a fine-tooth comb and looks at all of the toxicity, and is the benefit that we're seeing really outweighing that toxicity? And if they decide this is effective and safe, they approve it. And then even after a drug has been approved, and when a drug is approved, it's available for people in the community, and it doesn't need, you don't need to be a part of a clinical trial to get this drug. However, they continue phase 4 monitoring of the medication. So if you have a new drug or a new therapy, there are continued reviews by the FDA of, once you start getting it into the general population, is it still safe? Are we seeing new side effects? And we do tend to see new things that come out when it's used more broadly than in these very controlled clinical trials. If you have any questions about clinical trials, the first place to talk to is your oncologist. We all know our fields pretty well and know of options. But sometimes oncologists don't know everything, and sometimes in the community there are oncologists who treat every kind of cancer, and it's very hard to stay on top of all of these trials. And so another option, very good option for this, is clinicaltrials.gov. This is a national database of all of the studies available in the United States. And you can search by your cancer type, you can search by sites, you can search by whether you're looking for a phase 1 or a phase 3 trial. And it's a lot of information. And again, often what you get on clinicaltrials.gov, you need to bring back to your oncologist to make sure that the trial that you found is actually fitting what is going on with you, but is a very, very powerful resource that we have in the United States. And then also your local disease cancer specific websites. Again, I know breast cancer, so breastcancer.org. The American Cancer Society has some amazing resources and is a wonderful society to get involved in, and so that is also very important. And I actually see a question. So a patient can enter at any phase of the study. What you will be entering is a specific study. So if, for example, and every time that you go to you are interested in a study, you will have you will be told what the risks and the benefits are and what type of study you're getting involved in, so that you can always decide, you know what, this doesn't sound like something I want. I don't want to get a placebo. I don't like the toxicities that you're talking about. And that really is the patient's decision. Your oncologist can recommend studies and say, I think this is a good study for you. But it is always in these clinical trials, particularly because we don't know the benefits, completely know the benefits and risks of these trials. That's what we're trying to figure out. It is the patient that is the center and gets to make those decisions. Does that help? All right, next slide. So oncology, we used to have 3 pillars of oncology, and I was a classics major in college, so I always liked the classical history. But we used to have 3 pillars in oncology. We had surgery, radiation, and chemotherapy. Surgery, we've had around since the Egyptians and before. We have found mummies that have had breast cancers, and we have found mummies that have had mastectomies. So we know that surgery is sort of our oldest part of treating cancer. In the 1900s, when radium was discovered, we then also had radiation. And so surgery in combination with radiation was really the standard for cancers. And in the 1940s is when we then discovered chemotherapy. It was actually due to World War I and the nitrogen mustard gases and side effects that were seen with nitrogen mustard gases from World War I that really started the chemotherapy arm of cancer therapy. And that has very, very much exploded since then. And really only in the last 10 to 15 years has immunotherapy come on the scene, and has really become a mainstay in a variety of different cancer therapies. So really these are the pillars of when someone's talking to you about cancer therapy, in any stage, these are really what they will be talking to you about. Next slide. So immunotherapy. So we really are getting better at figuring out what is going on with tumors. And we know that your immune system is a very, very balanced system that is trying to scan your body and figure out things that may be attacking your body or making your body sick. And it's very focused on infections because those are really what kind of attacks our body every day, are viruses and bacteria. And so it finds those by knowing what is self, what is your body, and knowing what is not self, or a bacteria, a virus, a cell that's infected with a bacteria and virus. And so it's very fine-tuned for that. Unfortunately, with cancer, cancer is yourself. And so your body can react to it in 3 different ways. We see some tumors that we call hot or inflamed tumors. So in all of these pictures, the tumor is the purple and the green are the immune cells. And so basically in hot inflamed tumors, there are a lot of immune cells that are all mixed in with the tumor and clearly have found the tumor and gone to the tumor. However, they're not working the way they should. And the tumor finds ways to tell them, please don't come here, please calm down, don't react. And so for these hot inflamed tumors, we have to find ways to reactivate the immune system and get it to do its job. And these hot inflamed tumors we see a lot of them in melanoma and in lung cancer, because those are cancers that are caused by carcinogens, by smoking, by sun exposure, and they therefore have a lot of mutations, a lot of changes in the tumor that make the immune system recognize it more. Say, okay, this isn't a normal cell in your body. We also can see this in people who have genetic predisposition for cancers. So BRCA, BRCA mutation carriers don't do spell check that well on their genes, and they can get a lot of mutations. And so we see a lot of them have more immune infiltrated tumors. Cold excluded tumors, and having said lung cancer and melanoma have these hot inflamed tumors, not all lung cancers and melanomas do that. And so a lot of what I'm going to be talking about is how we use our knowledge of immunity and our immune therapies to try to teach the immune system to make these hot inflamed tumors that we can then try to get that immunity active and destroy the cancer. Cold exclude, and so all cancer types can have sort of all 3 of these types of immune responses. And we are now in our research really trying to figure out how we can use our toolbox of immunity to treat each of these different types of cancers. The cold excluded tumors are tumors where the immune system has seen it. You can see all of those green cells all surrounding that tumor, but for some reason they're not able to get in. And this is often because the tumor either figures out ways to hide from the immune system. It hides any kind of receptor that may trigger the immune system to enter the tumor, or it induces chemicals that basically tell the immune system to go away and don't look here. Type chemicals. And then, and we see a lot of these cold excluded tumors in breast cancer. We have a lot of tumors that somehow the immune system just doesn't see that tumor. In the cold ignored tumors, these are now tumors that your immune system just hasn't seen for whatever reason. Often pancreatic cancer, there's a lot of pancreatic cancers that just have no immune response in them. And one of the reasons for pancreatic cancer, we think it is that they develop this sheath, this fibrocystic sheath on the outside of the tumor that just really doesn't let the immune system, which is in the blood, see that tumor. Next slide. So if we look even further into immunity, we question what kind of immune cells do we need to develop this effective immunity? And again, I'm giving you a very, very broad view of this, and I am a T cell biologist. So I talk a lot about T cells. If you get a dendritic cell biologist, they're going to talk about dendritic cells. We all have our favorite immune cells, but the immune system is very, very complicated. Basically, what we have immune cells that increase the tumor seeing the immune cell system seeing the tumor, and when they're active, they actively kill the tumor. And we have cells that dampen down that immune system. And if you think about an infection, that you want both of those types of cells. So if you cut your finger, you know that immediately your finger gets red and warm and hot, and that is the immune system ramping up to kill any bacteria that got into that cut in your finger. But you wouldn't want that to be red and warm and hot forever. You'd then want, after the bacteria was gone, for your immune system to then taper itself down and say, okay, that's it, immunity, we don't need this response anymore, and not have to worry about that. So in cancer, the type of immune cells that we want to get are type 1 immune cells. And we have CD8 cells, which we call cytotoxic lymphocytes, which is exactly what they do. They kill cells. Cyto is cell, toxic is kill. So when they're active, are very active to attack and destroy tumor cells. However, we also have CD4 T cells, and we call these helper T cells. And these cells support those CD8 T cells. They release chemicals that make those CD8 T cells active. They bring in other parts of the immune system so that they can the CD8 T cells can even more effectively do their job. And so those are the types of cells we want in the cancer that will be able to destroy the cancer. However, when your immune system gets ramped up and starts working, we also have the cells that tune it down, and those can include B cells. These are the cells that make antibodies. So that's what you're seeing all over his head are these antibodies, and regulatory T cells. These are called type 2 helper T cells, and they basically secrete chemicals that say, okay, don't do anything to the immune system, tamper this immune system down. And so it's really a balance of these two types of immunity. Now, when we get an increase in these type 1 T cells, those CD8 T cells, when one of the other things that they can do is develop memory T cells. And these are the immune response that can come back if they happen to see the same infection again. This is what you get with a flu shot. So when you get a flu shot at the beginning of the year, the goal of the flu shot is to develop an immune response that will induce memory. It will induce these T cells so that if you ever see that cancer again, or excuse me, that flu, the flu that you're being vaccinated against, if you actually see that virus, you will destroy that virus and you won't get sick. So that's why after you get the flu shot, you kind of feel achy and flu-like for a few days afterwards. It's your immune system reacting to that vaccine, just like it would react to the flu, with the goal that the next time you see that virus, you're going to destroy it, not get sick by it. Next slide, please. So really what we are with prevention vaccines and with what I'm doing, what I'm researching in my lab, we're trying to, much like a flu shot, to teach a patient's immune system about a cancer and basically teach the immune system to see that cancer and destroy it such that you can never develop that cancer. And then if ever those abnormal cells are seen, they'll get rid of, your immune system will get rid of them and you would never even have a cancer. So that really is our goal, but we are still in the preclinical, we're still in that laboratory phase of that goal. So really with these cancer therapies, what we're doing is we have, we know from your biopsy, from your tumor, your immune type, how much immune cells are in your tumor. And then using a variety of different methods, chemotherapy actually can change the immune response to the tumor, vaccines and vaccine adjuvants, cytokines, which are those chemicals that change the immune environment, immunomodulatory antibodies, and then what, quite honestly, I wrote this review. So what we didn't have at the time this review was written were T cell therapies and particularly genetically modified T cell therapies. And I'm going to talk about each of those in general. Next slide, please. So these are the things I'm going to talk about. Next slide. Cancer antibodies. So I know this is a scary slide with lots of science on it, but really what I want you to get away from this is if you are getting a therapy and the last 3 letters of that therapy are MAB, that means you are getting a monoclonal antibody. And so we name all of our antibody therapies as MAB. And what an antibody is, and in science, we always write it this way. We write it as a Y. And I don't know if you can see, you can't see my marker, but basically the 2 orange parts, the small short arms are very specific. These recognize a specific part of a protein on a cancer and therefore will find that specific cancer receptor and bind to it. And then the blue part, the long part, is called the FC portion, and that portion brings the rest of the immune system. So these antibodies are made so that they specifically recognize a marker, a target, and then they bring a lot of immune cells to that target, as well as we make these antibodies such that they block receptors and keep them from signaling and to prevent cancer from growing. And so every MAB is an antibody, and how much of that antibody is human versus made in a laboratory and typically a mouse is by the suffix. So if anybody's ever had leukemia or lymphoma and received something called rituximab, or which is Rituxan is the brand name, and it is a chimeric antigen. It's got about 65% human. And so its last end of its suffix is ZMAB, Ximab. And it is against CD20, which is a B cell marker. If you've had breast cancer or gastric cancer or certain types of colon cancer, you may have received trastuzumab or pertuzumab, so Herceptin or Perjeta. And you can see them down at the bottom here. They are both for HER2 positive disease, and HER2 is a receptor that is on the outside of your cell, and it has to bind, it has to group with another HER2 molecule, another HER molecule. And trastuzumab basically blocks that from happening so that you can't get growth of the tumor. And pertuzumab blocks it in another way. So you just see there where specifically they bind. But not only do they block growth of the tumor, but they also can bring in other parts of the immune system through that, again, that blue long FC portion. And the other parts of the immune system further amplify and destroy the cancer. And so ZUMAB is that they're mostly human, 90% humanized. And so trastuzumab, pertuzumab, pembrolizumab, if anyone's had lung cancer and had that immune checkpoint inhibitor, which we'll talk about in the next slide. And then there are 100% human antibodies. Panitumumab, which is a EGFR inhibitor for colon cancer, is an example of the UMABs, which are the ends. So all I want you to know is that if you're ever getting MAB therapy, and these are FDA approved and have been used for decades. Trastuzumab, which is the one I'm most familiar with, I remember when it came on when it was first presented, those phase 3 randomized trials that showed this huge benefit in 1998 or 9. It was a long time ago. So these are very well established therapies, these monoclonal antibody therapies. Next slide. Now in cancer, immune checkpoint therapies are also very established FDA therapies. And Jim Allison at MD Anderson won the Nobel Prize for this about 2 years ago for discovering immune checkpoint. And his immune checkpoint that he discovered is CTLA-4 and called ipilimumab. So what immune checkpoints are if you remember those hot tumors, those tumors that had a lot of immune cells in them, the tumor cells, those immune cells came to the tumor and then the tumor turns them off so that they're not really working well. And it does that through a series of receptors that basically say, stop working, don't kill us. And the tumor is able to escape the immune response that way. And so again, remember, these T cells are very specific. So they have a T cell receptor that recognizes an antigen, which is a small piece of protein that is very specific to that tumor. And they also need to be active. And to be active, to have a go signal, they have a receptor that is called CD28. But to have a stop signal, their receptors are PDL1, which is that yellow receptor, and PD1, which is that orange receptor. And so basically these immune checkpoint blockades, all they are antibodies that block those receptors. So now if you look by the green arrow, that PDL1 is being blocked by that light green, which is an anti-PDL1 antibody. And one example of that is durvalumab. Remember, mAb, monoclonal antibody. And PD1, which is on the T cell, is blocked by an anti-PD1 antibody. So an example of that is pembrolizumab. So again, mAb, monoclonal antibody. And basically what that does is if there are immune cells in your tumor, it takes the brakes off of those immune cells, off of those T cells, and lets them go to town and allows your tumor to be attacked. And we have seen lots of benefit of these in lung cancer and actually in metastatic lung cancer. These are the first line therapy are immune checkpoint therapies. So basically these antibodies are letting that T cell go to do its job and stop being inhibited by the tumor. And we have a lot of therapies for this at the Earl Childs that are particularly in lung cancer and melanoma that are clinical trials, because we are really trying to figure out how to move these therapies earlier and earlier in therapy, in treatment. Right now, we treat them in people who have metastatic disease and disease that's spread throughout the body. And we want to be able to use them, although they'll be the most benefit, which may be in earlier disease. So in breast cancer, sometimes we have to give chemotherapy before we do surgery in order to shrink that cancer down. And in triple negative breast cancer, we found that adding pembrolizumab, adding these immune checkpoint inhibitors in a small group of those triple negative breast cancer patients with that neoadjuvant chemotherapy actually really benefits them, their outcome, and has more of them develop this pathologic complete response, which is what we are aiming for in early breast cancer. So we are figuring out how to move these drugs earlier and earlier, and we're doing that with clinical trials. Next slide. So now we are leaving FDA approved and we're going to vaccines. So again, as I talked about earlier, what we want to do with vaccines is teach your immune system to see your tumor and fight it. And sometimes we have to do that by showing your immune system antigens, that parts of the tumor that it may not normally see. We kind of have two types of tumor vaccines that we're studying. We study vaccines against overexpressed tumor proteins. So basically these are proteins that are in normal cells, but that in the tumor are higher expressed. For example, HER2 is a very good expression in a small number, in about 15 to 20% of breast cancers and about 5% of esophageal cancers. There is this increase in this HER2 receptor, and that actually is what drives the growth of those cancers. And so having a vaccine that would teach your immune system to see that HER2 as abnormal when it's overexpressed and attack it is a way to develop vaccines and develop vaccines such that you could give a vaccine to a lot of different people. The other type of vaccine that we do is something called neoantigen. And what neoantigen means is that as what has caused these tumors to develop is that they have a lot of mutations. And these are immune responses specifically to the tumor mutations. So these are very specific to your individual tumors. However, neoantigens can be such that you would develop an immune response specifically to your tumor and not to other normal parts of your body, because you're developing an immune response specifically to a mutation that's only found in your tumor. And Eric Tran, who is at the Earl Childs, is doing a lot of research in how to identify these neoantigens or new antigens. They're very, very person specific. So you'd have to have your tumor genetically screened for this. But there are a lot of labs around the country that are trying to really develop these. Next slide. Thank you. And then there's cellular therapy. And this is basically giving you T cells or B cells and natural killer cells to fight your tumor. So instead of letting your body develop its own immune response, this is trying to give you an immune response. So these can include tumor infiltrating lymphocytes, T cell receptor engineered lymphocytes, and chimeric antigen engineered lymphocytes, CAR. And of these three, the one FDA approved is CAR T cells. You may have heard of it on television. It is specifically in leukemia and lymphoma. There is a Kiswali, which is a CD20 CAR T cell. So it is a T cell that they take T cells from your peripheral blood. They genetically modify them so that they are specifically fighting this CD20, this B cell, and then they give them back to patients. And in patients who have had very resistant leukemias, this has led them to be able to go on to a bone marrow transplant, which is really their only way of cure. Next slide. So really just to kind of walk you through what a TIL therapy is that you have a patient that you cut out their tumor and you take their tumor, and all of those colored circles are immune cells, are T cells in the tumor. And you figure out which of those T cells, you select a specific T cell, grow it up, which is what all of that bottom at the 6 o'clock position is showing. And then you show those T cells back to the tumor and see which of those T cells, which are those two red pluses, will fight the tumor. You grow those up to a very large amount, 10 million cells, all of these cells really focused on fighting that tumor. And then you give them back to the patient and see how they respond. Next slide. Anyone who has had cancer has had, particularly more advanced cancers, has had CAT scans. So what we're looking at here are a panel of 3 CAT scans. This is actually a slide that was given to me by my friend Stephanie Goff, who is at the National Cancer Institute. She is part of the Rosenberg Lab, and Steve Rosenberg was really the pioneer at tumor infiltrating lymphocytes and giving these T cells back to patients. And so this is a patient who had cholangiocarcinoma, which is carcinoma of the gallbladder. And as you can see on the far left of your screen, there are lots and lots of holes in that liver. What we're looking at now is a cut sliced through the patient showing his liver. Those are all pieces of cancer. So cholangiocarcinoma tends to go to the liver and fill the liver. And he had a piece of liver taken, and they found those T cells that were in his tumor and grew them up. And then how the Rosenberg Lab does it, and if anyone has advanced cancer and the wherewithal to get to the National Cancer Institute, it is an institute funded by by our tax money, and they accept people and they run clinical trials. That is what they do. And the Rosenberg Lab has continued to do this and do this in multiple different types of therapy. So it is an option, but it unfortunately, when we're on the West Coast, is hard to get to the East Coast, to get to DC and to stay in DC long enough to have a therapy like this. But what happens is that the gentleman got his T cells back, and you can see 34 days after that liver is clean. And he actually stayed out up to 7 years without having recurrence. So very, very exciting, but it tends to be a one-off patient because, again, it was his T cells that specifically, he had enough of them in his tumor that recognized his tumor that they could expand and give back to him. Next slide. So another way to do this is to look for T cells that recognize mutations in your tumor, neoantigens. And this is also from Stephanie Goff, but is actually a special patient for us because we teach a class every summer, well, except this summer, where we teach breast cancer advocates. At one of our, we teach immunology, and we teach the basics of immunology and go into way more detail about all the cells and what they do. And then we teach cancer immunology. And one of the cancer patients who was there came up to us, and she's a breast cancer advocate. And she said, my doctors have told me I've done all my therapies and I am done and I want more. And so she went to the NCI again, and they actually biopsied her tumor, and they found all of the T cells that were directed against mutations to her tumor. And they gave them back to her along with pembrolizumab, that immune checkpoint inhibitor. And she had a complete response. And this response was 14 months out, and she went and hiked some big mountain and was just very active and doing well after getting her T cells back. I didn't have a chance to talk to Stephanie this year to see how she's doing now. But so these are very exciting therapies. Having said that, Stephanie always, when she presents this, says, and we did 18 breast cancer patients, and this is the best response we had. So these are very exciting when they work, but often we are still figuring out what we need to do for tumor infiltrating lymphocytes and being able to do this. Next slide. So then one of the problems is that some people don't have T cells in their tumor that are directed against their tumor. Remember those cold tumors that didn't have this. So this is where we try to make those T cells by genetically modifying T cells so that they specifically recognize your tumor. And we either do this by genetically putting in a T cell receptor that is specific to a particular protein on your tumor, on a tumor, or by putting in an entire T cell complex so that not only is it recognizing the tumor, but it's also the T cell is super active and super going to attack the tumor. And that is the CAR T cell complex. And we have a very active interest in this in Earl Childs, and particularly in trying to do this in what we call solid tumors, which are breast, head and neck, colon, pancreas, because right now, these CAR T cell and T cell receptor studies have been very effective in liquid tumors, in myeloma, in leukemia, in some lymphomas. But we have been struggling in the solid tumors to figure out a target, because remember, we have what typically in leukemia happens is that you target your CAR T cell against a B cell. You basically destroy all the B cells in the body. And those include the leukemia B cells, but they're also healthy B cells. And patients who've had these CAR therapies, B cell CAR therapies, have to get B cell infusions because they lose all of the B cells in their body. Well, in solid tumors and in breast cancer, we can't do that with HER2 because HER2 is expressed in the heart and HER2 is expressed in the lungs, and it has normal functions in the body. And so we are trying to figure out how to change these CAR T cells to make them such that they will just target the tumor and they won't target other parts of your body. And so we have looked at the TCR, just doing the T cell receptor in pancreatic cancer with Eric Tran's lab again at the Earl Childs. We have done several of these studies in head and neck and melanoma, and particularly using HPV targeted T cell receptors in HPV driven melanoma, head and neck. And what that is that there is a virus that can cause a certain percentage of the head and neck cancers. The HPV virus. It's the same virus that can cause cervical cancer. And so we had some studies, because remember, viruses are not self. And so you would only be targeting these HPV positive cells, which would be tumor cells. And so we had clinical trials and actually have clinical trials open for head and neck cancer, again, looking for these T cell receptors. And we've also had them in melanoma and other trials. And so any interest really that I would be to talk to the clinical trials group here at Providence Portland. Next slide. So I have given you a ton of information and realize that it has to be digested. So please, please, please ask questions, and please, please, please also if things just don't continue to be clarified, I'd be happy to talk further. And so we know that cancer immunotherapy is successful. It's particularly successful in tumors that have a lot of mutations or that have a lot of immune cells in them. Melanoma, lung cancer, renal cell carcinoma, some colon cancers. Really, we've mostly seen benefit in triple negative breast cancer. However, we have so many other types of tumors that we need to find good therapies for. And so what we're trying to do now is, instead of look at the type of cancer, look more at the type of immune response developed in that cancer, and then figure out how we can improve that. So checkpoint blockade, those were those antibodies. They can help if there's already immune cells in that tumor that can then be activated. Vaccines can help teach the immune system that cancers are not self, and develop an immune response in tumors that may not have an immune response. And those adoptive cell therapies, right now, those are really last stage. Those tend to be in the metastatic setting, and they can give more T cells and specific T cells that can then fight the tumor. Next slide. If you have any questions, this is my email. You'll get the slide deck, and my email will be in it. Really, please do feel free to reach out to me. I give all my patients my email, and as I tell all my patients, the only thing I have to warn you is I am also a night owl. So if I didn't have to work a real job, I would not be wanting to get up at 8 o'clock in the morning. So if you email me at 3 o'clock in the morning, you may get a response because I may still be up. So, and if you are interested in any of the clinical trials from Providence, you are welcome to email me and I can forward your information, or this is our website, and it will give you a phone number and contact information, and places both for patients to contact and physicians to contact. And that is a very good question. Side effects of immunotherapy. Yes, there are definitely side effects of immunotherapy, and we are having to learn new side effects, because the side effects that we see in immunotherapy are very different from the side effects that we see in chemotherapy. So the immune checkpoint inhibitors, about 15% of them will get immune side effects. And these can be as severe as heart problems, where your immune system, because remember, you're taking that break off of the T cells. And our hope is they would just act in the tumor, but we also see them acting elsewhere in the body. So if they act at the heart, you can have heart problems. And this is particularly, we see it when we add ipilimumab and the pertuzumab. So the CTLA-4 and the PD-1 together, we get more trouble with heart problems and people having enlarged hearts from the immune system attacking the heart. You can have colitis, so diarrhea from the immune system attacking the colon, and pneumonitis, or lung issues where the immune system attacks the lungs. A lot of these side effects can be reversed with steroids, with something that dampens down your immune system, but absolutely, and very good question. None of these have no toxicity. They still have toxicity. The CAR T cells, which is sort of the other end of the spectrum, these are still only given in very specialized clinics. We give them here. We have them at Providence Portland. They have them up at OHSU. And we have an immunotherapy clinic up at the Seattle Cancer Care Alliance, so the University of Washington. We were one of the two big centers, us and University of Pennsylvania, that originally designed CAR T cells. So when you're going to be receiving those, you have to go to a center to get them, because they have a lot of side effects. And these can include an inflammatory immune response that causes you to be in the ICU. You have trouble breathing, and you have very high fevers, and it's all because your immune system is just hyperactive. Interestingly, in COVID, We have a medication called tocilizumab that was designed to control the side effects of CAR T cells. And so all of us oncologists knew much more about it than all of the ICU doctors and infectious disease doctors. And it has been rejiggered to work for the same kind of cytokine storm that you can see in COVID, in serious COVID infections. And so it's been a lot of oncology teaching infectious disease about all of these new medications that they didn't know about. Anyway, that's sort of a side note. Can you withdraw from clinical trials for side effects? Absolutely, always. So the clinical trial is a gift that you are giving us to learn more about the cancer and the best way to treat it. And you can withdraw from a clinical trial for any reason because it's too hard to go to the appointments, because often there are more appointments, more blood draws and things like that. So absolutely you can withdraw from a clinical trial for any reason and due to side effects. And typically with clinical trials, we actually have what we call stop trial where if somebody has a severe enough side effect, we actually will stop the trial because of a bad enough side effect. Or if enough people have the same bad side effect, that is a sign to stop the trial. And so absolutely you can, there is, for clinical trials, even after you sign a consent, you can always say, you know what, I don't want to do this and pull out. And that is a patient's rights. I have to say with clinical trials, we very much struggle, and I ran a lot of immuno trials up in Seattle and doing so down here. We don't have a lot of Asian Americans who join clinical trials. Our clinical trials in general tend to be very Caucasian heavy. And that is an issue because we don't always get information. We know we're not all the same. And we know that different genetic groups respond differently to therapies. We see that in chemotherapy. We have certain chemotherapies that are actually much more effective in Asia. And so there is a chemotherapy called S1 that is only available in Asia. It's not available in the United States. And the reason why is that we didn't get the same results that they did. And it's genetics, it's difference in population. So having a wide swath of Americans involved in clinical trials is critical for us because it really lets us know that this therapy is effective and safe across all different groups of people. So absolutely, but it is also always the patient's right to drop out. And side effects is a huge one, and one that we very much take seriously. So when or in what stage to seek immunotherapy? Very good question. There are many stages to seek immunotherapy. Really for the CAR T cells, the T cell therapies, it is typically late stage. So people who have metastatic disease, but we have immunotherapy trials. We are working on getting a vaccine trial, a trial that actually is looking at vaccination plus radiation, and vaccination plus a chemotherapy agent, a very low dose of a chemotherapy agent in early breast cancer prior to surgery. And we are hoping to get that going pretty soon here. So we have immune therapy trials spanning all the way from that, which is a very early breast cancer trial, all the way to, immunotherapy trials that are in people who have very advanced disease. And I did not answer this, and thank you. This is a very good question. Immunotherapy is not only vaccinations. The vaccines actually can be given in many ways. Some of the vaccines are given right into the tumor. Some of the vaccines are given in the arm, just like you'd get a flu shot. monoclonal antibodies, the mAbs, are all given by infusion. They're given into a vein in either your arm or in a port if you're if you have a port in for chemotherapy. The CAR T cells are infused just like you'd get a blood transfusion. I have had patients feel very that kind of feel it's very anticlimactic when they get their CAR T cells, because they just sit there and they drain in just like you'd get a blood transfusion, and they're like, well, that was not as exciting as I expected. So immunotherapy is given in many, many ways, and we are actually trying to figure out how best to give it. We don't have any immunotherapy at this time that is oral, so we don't have anything that's a pill. Everything is given by infusion. Having said that, we are finding a lot of things that we think have some immune responses that are pills. So for example, in colon cancer, aspirin has been shown to inhibit adenomas and pre-colon cancers. And some of that aspirin related effect is immune related. It is a COX-2 inhibitor, and COX-2 is an immunosuppressive part of the immune system. So immunotherapy, many things can be immunotherapy, and it's given in many different ways. How is that for a wishy-washy answer? Really, thank you guys so much. And any questions, please feel free to email me. Again, I am a fast talker, so I do apologize for that.